Hello, everybody. This is Dr. Christy Day. I've prepared a video that is aimed at providing some study tips for exam 2. This time I've broken up the content by weeks instead of combining all of the content into one large review. The video is not intended to be a comprehensive lecture of the content material, but instead it aims to highlight some topics and focus your study. Your major source of study for this week are your textbook, Fitzgerald Amplify, course lectures, and also the CDC website for STI content. And of course, listening to this content is optional. I've provided this slide so that you can see what is available within the course to help you prepare for the exam. You can find this file in week 6 instructional content, and it's called Study Guide Template, and you can download it to your computer, the actual file that's editable. In previous courses, completing the table was a course requirement and was graded, but completing this course for a grade is no longer required, but I highly recommend that you approach your studies focusing on the problems and their risk, symptoms, clinical presentation, screening and diagnostic testing, diagnostic criteria, and treatment options. Understanding the content in this way will help you in your clinical practice and the course exams, and also as you prepare for your board exams. Cancer of the breast is the second most common cancer in American women. It accounts for approximately 30% of all cancers in women. And breast cancer is second only to lung cancer as the leading cause of death among women and is the main cause of death in women aged 40 to 44 years. That's amazing. So early diagnosis is key to survival. And as a primary care provider, your role will be essential in improving outcomes for your patients who may develop breast cancer. Be sure to review the risk factors listed to understand early screening indications. In 2024, an estimated 310,000 women in the U.S. were diagnosed with invasive breast cancer, and more than 56,000 new cases of ductal carcinoma in situ were diagnosed. The projected number of women expected to die from breast cancer in 2025 is more than 42,000. Breast cancer isn't limited to men, but the incidence is much smaller, so don't let men drop completely off your radar. I have actually had a man that was diagnosed. We diagnosed him with breast cancer. And in 2024, approximately 530 men in the U.S. were projected to die from breast cancer. And this represents a small fraction of total breast cancer deaths, as men only make up about 1% of breast cancer diagnoses. But always, if you have a breast complaint from a male, always keep this on the radar. There's a very good explanation in your book about the BRCA1 and BRCA2 gene mutation and screening for that. And I recommend that you educate yourself a little bit more on those risk factors for breast cancer. A diagnostic mammogram is ordered in patients with palpable breast mass, suspicious nipple discharge, or a suspicious area on a screening mammogram. Routine screening mammograms are ordered unless they need a diagnostic mammogram. Suspicious findings on a mammogram might include asymmetry with definitive borders or discernible masses, an architectural distortion of pulling in breast structures, a nodule that is more radiodense, irregularly shaped, or has unclear margins, calcifications that are irregularly shaped, clustered, and varying sizes. Skin changes such as thickening or retraction, axillary or intramammary lymph nodes of more than 2 centimeters in diameter. So in this case, when you order a screening mammogram to begin with, and then you get your mammogram results back, I'm going to tell you that your radiologist is your friend in this situation. You can call them, you can talk to them, and you need to follow their recommendations. And their recommendations should be your guide to the next step for imaging. Most radiologists will request an ultrasound be completed in combination with a diagnostic mammogram. A spot compression flattens and isolates a lesion. A diagnostic mammogram determines the need for subsequent testing, such as a needle biopsy, and whether there's other suspicious areas that are present in one or both of the breasts. A patient diagnosed with breast cancer is referred to a cancer specialist. These include a surgical oncologist, a medical oncologist, and or a radiation oncologist. So they may have a team. And that team should provide comprehensive treatment for their cancer. And the choice of treatment is influenced by many factors, including their age, their general health, their estrogen and progesterone levels, and other prognostic factors. But when invasive breast cancer is started, treatment is started at an early age, such as surgery, radiation, chemotherapy, or hormone therapy, it can be highly curable. So that's the good news. As a primary care provider, we continue to manage patients who are living with breast cancer in our clinics. You may be helping the patient manage their chronic conditions or addressing an acute problem such as runny nose, sore throat, cough, GI concern. And for this reason, it's important for you to have an understanding of some of the treatments that they're receiving and their adverse effects, so that you will know if what you're seeing is something different or is it an adverse effect, and how serious is that adverse effect. For example, 2/3 of breast cancers are either estrogen receptor positive or progesterone receptor positive. Hormonal therapy is effective for these cancers and includes the use of anti-estrogens such as tamoxifen, progestins, luteinizing hormone-releasing hormone agonists, and aromatase inhibitors. By far, tamoxifen is the most commonly prescribed of these agents, and the treatment period is 5 years. If you think about an anti-estrogen medication lowering a woman's estrogen levels, there's a potential adverse effect such as nausea, hot flashes, menstrual irregularities, vaginal discharge, vaginal dryness and irritation, benign ovarian cysts, thrombotic events, and ophthalmological toxicities. And these are things that you're if you see a patient on tamoxifen, go and look it up, see what you should be looking for when they have a complaint. And also it may change your screening criteria. The issue is also that tamoxifen also exhibits an estrogenic effect on the uterine endometrium. And therefore you may see an increased incidence of endometrial cancer. Mastitis is a general term that refers to inflammation of the breast. Puerperal mastitis or lactational mastitis is a cellulitis that develops after childbirth. The most common cause for puerperal mastitis is Staphylococcus aureus, which is a gram-positive organism, and can also be MRSA. It's more common in patients who breastfeed rather than bottle feed their infants, and due to the prolonged engorgement of the milk ducts. It usually occurs in the 2nd to 6th week postpartum, but we've seen it in patients even after breastfeeding for a year. The clinical presentation is acute in nature. The patient's first complaint may be fatigue, followed by flu-like symptoms such as nausea and vomiting, breast tenderness, myalgia, malaise, chills. You may see redness and warmth to the affected area on the breast. They can have a fever, usually greater than 100, and feel very ill. For diagnosis, milk cultures are rarely done in the first occurrence unless there's a reoccurrence, because it's costly and it can delay treatment. The most important thing is to get these patients their empirical broad spectrum antibiotic within 24 hours of the start of symptoms. Without treatment, only 15% of patients will recover without recurrent infection, and approximately 50% improve with breast pumping alone, and more than 95% recover when there's a combination of breast pumping and antibiotics. Bed rest is indicated during the acute phase of the illness. The patient should be assisted with household duties and rest in their bed with their infant. Moist heat, massage to the breast can be helpful, and pain and other uncomfortable symptoms should be treated with non-steroidal analgesics. And the main thing is it's vital that the infant continue to breastfeed to avoid milk stasis. We want to keep the breast, emptied, and that will help get well quicker. Because the infection is extraductal, there's no risk to the infant in continuing to breastfeed. It's different if they have HIV, but for normal, healthy breastfeeding women, feeding helps to drain the breast, and in addition, pumping may be needed. But remember that the more that the breast is stimulated, the more milk they're going to produce, so it's sort of a double-edged sword. Non-puerperal mastitis is a rare disease found in patients who are immunocompromised, they've undergone radiation therapy, or have an autoimmune disorder. Patients with periductal mastitis are often asymptomatic. Others will present with breast pain or tenderness, a breast mass, nipple discharge, a retracted nipple, a breast abscess, or a mammary fistula. And the pain is usually focused behind the areola and tends to be more severe in younger patients. Nipple discharge varies in color and may be bloody, and it's often green and sticky, and occurs spontaneously. It doesn't need to be expressed. Contraception and family planning is the prevention and unintended pregnancy, and also can help with the transmission of sexually transmitted infections. The most effective family planning methods are implants and IUDs, and these are reversible. And of course, sterilization, male and female, which are the only non-reversible birth control methods, and those are at the highest level, the most effective. And you can see on this chart from the CDC, which was also in your book. And be sure and review this chart and kind of understand the effectiveness and where it lands on the scale. The IUD is a highly effective reversible contraceptive method with a 99% effective rate. And it can be inserted into the uterus by a trained clinician, and the procedure can be done anytime during the menstrual cycle in a non-pregnant patient. The mechanism of action is not completely understood. They think it has to do with acts as a spermicide or an inhibitory effect on the sperm's ability to fertilize the ovum and transport. However, an IUD is not an abortion, and contrary to previous thought, nulliparity is not a contraindication to IUD use. In the past, they thought, well, if you've never had a pregnancy, then you shouldn't have one. There's several types of IUDs on the market, and those, some have hormones and some don't. As far as the estrogen implant, etanogestrel implant, Nexplanon, it's a highly effective, greater than 99% form of birth control consisting of a flexible 4-centimeter single hormone containing rod that's inserted subdermally in the upper arm. The implant contains 68 milligrams of the medication. It's released slowly over 3 years. It can be inserted anytime in a non-pregnant patient. However, backup contraceptive should be used if insertion occurs more than 5 days after the start of the period. The risks of the contraceptive method outweigh its benefits for patients with the following conditions. This means that if they have these conditions, the risks are too high compared to the benefits, such as cirrhosis, liver tumors, systemic lupus erythematosus, and an unexplained vaginal bleeding. Use of the implant is contraindicated in patients with breast cancer. Oral contraceptives contain either a combination of estrogen and progestin, or can be progestin only. The most popular oral contraceptives are the 4-week cycle combination pills, and combination oral contraceptives have a failure rate of 3% when used correctly, but the failure rate is 8% with typical use due to non-adherence and prescribed instruction failure to follow those. The amount of estrogen and progestin in combined oral contraceptives has been greatly reduced since their inception. The lower the effective dose, the lower the rate of adverse effects, and the lowest acceptable dose is guided by the ability of the medication to prevent breakthrough bleeding, which is an undesirable adverse event. Positive outcomes of oral contraceptive use can include reduction in anemia, ovarian cysts, dysmenorrhea, ovarian and endometrial cancers, control of acne, and others. In the presence of certain medical conditions, the risks associated with combined oral contraceptive are too high to outweigh any benefit of taking this medication. The risks that would preclude, contraindicate using a combined oral contraceptive include breast cancer, being less than 21 days postpartum, severe cirrhosis of the liver, current or past history of DVT, a major surgery with prolonged immobilization, vascular disease, having diabetes for more than 20 years, diabetic retinopathy, and a history of migraine with aura. Other conditions in which the risk typically outweighs the benefits include a history of breast cancer with no disease for 5 years or less, and an identifiable risk for DVT or cholestasis. The progestin-only pill or mini pill contains progestin exclusively and has a reported failure rate of 1 to 4%, which is slightly higher than combined oral contraceptives. Progestin-only pills are taken continuously beginning the first day of the menstrual cycle, and it inhibits ovulation, but also causes a thickening of the cervical mucus, which creates a hostile environment for sperm, and it alters ovum transport. But it can lead to a higher risk for ectopic pregnancy, and it also inhibits implantation of the ovum. The advantages of the mini pill are that it's safe during lactation and may increase the flow of milk, and it can be used by patients older than 35 years and by those with sickle cell disease or myomas. The progestin-only pill is also less likely than combination oral contraceptives to have adverse effects such as headaches, high blood pressure, depression, cramps, PMS, and elevations in glucose. All progestins, even in low doses, offer excellent cycle control and with minimal metabolic changes. The third generation progestins are the least androgenic and are preferred for patients with acne or hirsutism. And there's a certain type of the progestin-only pill that has a 1.5 times increased risk for developing blood clots, and that's drospirenone. I got it. Be sure to review the patient education for self-administration, including if your patient misses a dose. The transdermal contraceptive patch is a highly effective form of contraception. The mechanism of action is similar to that of combined oral contraceptive pills, but it has potential advantages over the pills. Because the patch is continuous transdermal delivery, hormone levels are constant without peaks and troughs, and compliance with use is improved. Additionally, transdermal administration bypasses the liver, so there is no first pass hepatic metabolism, which allows for lower doses to achieve effectiveness. The effectiveness is 99% if used perfectly and 91% in typical use. Keep in mind that obesity can decrease the effectiveness of the patch. Because the patch is a combined hormonal contraceptive, the eligibility criteria for its use are the same as for oral contraceptive pills. The contraindications to the contraceptive patch are also the same. The contraceptive vaginal ring, such as NuvaRing, is a combined hormonal contraceptive containing both estrogen and progestin and has the same benefits as an oral contraceptive pill. And the transdermal patch, but the advantage is that it's left in place for 3 weeks. So like the patch, the vaginal ring also has the advantage of consistent hormone release without peaks and troughs. Rather, the hormone levels peak immediately after insertion and then slowly decrease after a 3-week cycle. There's also no first pass loss of active hormones in the liver because they're absorbed vaginally, and the medication concentration is also lower than oral contraceptive pills. Depomedroxyprogesterone acetate, or DMPA, is available in several long-acting forms of contraception, and you can read more about these various types and the dosing regimens. Use of the DMPA is contraindicated in the patient if the patient is pregnant or has breast cancer. Risk will outweigh the benefit of DMPA in patients with the following conditions: undiagnosed vaginal bleeding, current or past breast cancer, thromboembolic disorders, cerebral vascular or cardiovascular disease, and high risk for cardiovascular disease, severe hypertension, hepatic tumors or active hepatic disease, papilledema and other eye disorders, systemic lupus erythematosus, or severe thrombocytopenia. The use of DMPA is associated with an increase in weight and percent of body fat over that of oral contraceptive pills. In 2004, the FDA issued a product label boxed warning on the long-term use of DMPA because of the possibility of bone loss bone mineral density loss. However, it's unclear whether there's an increase in fracture risk later in life, and the World Health Organization concluded that there's no reason to restrict DMPA's use in patients aged 18 to 45 years. On the other hand, barrier methods of contraception that prevent contact between sperm and the ovum include male and female condoms, the diaphragm, and the cervical cap. Some barrier methods have a dual advantage of preventing pregnancy and STIs. And the most common STIs are caused by herpes virus, HPV, HIV, gonorrhea, chlamydia. Preventing HPV infection also reduces the risk of cervical cancer. Adverse effects and challenges with the use of barrier methods include messiness, handling of the genitalia, precoital interruption of spontaneity, and allergy or contact dermatitis to the component materials or lubricants. In turn, the use of barrier methods requires motivation on the part of both partners. Condom use is promoted based on the general principles of preventing STIs rather than on the epidemiological data for all STIs because protection against HPV transmission is not 100% effective. HPV can be found in many genital areas, in the genital tract skin and mucous membranes. Hence, condoms do not protect the vulva from microscopic HPV particles on the skin. Sterilization is a permanent method of birth control. After the risks and benefits of sterilization are reviewed with the patient, an informed consent must be obtained. Up to 10% of patients who undergo sterilization procedures later request reversal of sterilization, particularly in patients younger than 30 years of age. Male sterilization consists of vasectomy performed on an outpatient basis. The procedure usually takes 20 minutes and is performed under local anesthesia. Complications include hematoma, sperm granuloma, and spontaneous reanastomosis of the vas deferens. After vasectomy, the patient is not considered sterile until the 2 sperm-free ejaculates have been produced. Semen analysis should be performed at 18 to 16 weeks after the procedure. About 15 to 20 ejaculations are required post-vasectomy to determine absolute sterility. Female sterilization can be performed in several ways. They can do a mini laparotomy, and that's usually done postpartum. And the procedure can also be performed laparoscopically through a small incision. Both of these require general anesthesia. Salpingectomy can also be done at the time of a cesarean section. Fertility awareness methods are also considered natural planning methods. Fertility awareness methods or the rhythm method, they're used for achieving pregnancy and preventing pregnancy. The patient will abstain from sexual intercourse during the days of the menstrual cycle when the ovum is most vulnerable to fertilization. And then body mucus, basal body temperature, cervical mucus, and the calendar are used to track. Cervical cancer screening is aimed at detecting precancerous changes to the cervical cells, and it's recommended for individuals with a cervix. In the vast majority of patients, if there's a hysterectomy performed, the cervix is also removed. But keep in mind that if a patient's cervix was removed because of cervical dysplasia, there are some specialty organizations that recommend testing of the cervix site moving forward. The American Cancer Society recommends the primary HPV test as the preferred test for cervical cancer screening. They recommend screening begin at age 25 and continue through age 65. A primary HPV test is an HPV test that is done by itself for screening. The U.S. Food and Drug Administration has approved certain tests to be classified as primary HPV tests. Some HPV tests are approved only as part of a co-test when the HPV test and the Pap test are done at the same time to screen for cervical cancer. Because a primary HPV test may not be an option everywhere, a co-test every 5 years or a Pap test every 3 years are still good options. You'll find that the USPSTF has recommendations along with the ACOG, the American College of Obstetrics and Gynecology. ACOG agrees with USPSTF recommendations, and they recommend that Pap smears begin at the age of 21 and continue every 3 years through the 20s. Pap smear is not indicated in lower age women, even if they have sexually transmitted disease risk. Cervical cancer screening schedules are not the recommendations for routine well-woman care. Even though you may only be having cervical cancer screening every 3 years, every 5 years, whatever schedule you're on, we still need to encourage women to have well-woman care with physical exams on a routine schedule. And the reason for this is that ovarian cancer does not have a screening test. The only screening for ovarian cancer is palpation of the ovaries for changes. And we don't want to let a patient go and never have an exam because they don't need cervical cancer screening. Think of it as the cervical cancer screening or Pap test is a lab test. It is a part of well-woman care, but it's not the sum total of well-woman care. HPV test results show whether high-risk HPV types were found in cervical cells. An HPV test will come back as a negative result or a positive test result. Negative HPV test results show that high-risk HPV was not found. So we should recommend that the patient have another test according to the schedule. Positive HPV test results show that high-risk HPV was found, and then we take appropriate actions. And sometimes after several negative HPV tests, a woman may have a positive HPV test. And this is not necessarily a sign of a new HPV infection. Sometimes an HPV infection can become active again after many years. And some other viruses also behave this way, such as chickenpox or shingles. Researchers don't know whether a reactivated HPV infection has the same risk of causing cervical cancer, cervical cell changes as a new HPV infection. Be sure to look at some pictures of HPV to know what infections look like on physical exam. There may be external indications or something that a patient is seeing. HPV 16 and 18 are most likely to cause cervical cancer. HPV Your textbook has a chart of cervical screening results, and you'll receive these type of results back when you get a report. Pay special attention to the squamous cell abnormalities and their intervention recommendations. Patients with pre-malignant cervical lesions may present with one or more of the following: a history of risk factors associated with the development of cervical cancer, a concurrent vaginal infection with symptoms, no recent gynecological care, and no cervical cytology screening for a long period of time. Females with invasive carcinoma may describe a brownish discharge or a history of abnormal vaginal bleeding occurring spontaneously or after intercourse. Female patients with a history of postcoital bleeding or irregular vaginal bleeding that cannot be explained should be referred to a gynecologist for further evaluation. Typically, only with extensive disease spread will other symptoms manifest from cancer, such as weight loss, decreased appetite, back pain, etc. Be sure to review the chart in your textbook related to differential diagnosis of chronic pelvic pain syndrome in women. Endometriosis in particular is a painful chronic disease. There's no cure. It presents with painful periods, pain during intercourse, pain on defecation, and infertility. Some of the management strategies are combined hormonal contraceptives, medroxyprogesterone acetate, implants, other hormonal agents, NSAIDs for pain, and they will sometimes do surgery to remove some of the endometriosis and also to look at for other pelvic pathology. There is also acute pelvic pain, which can be the result of pelvic disorders, including pelvic inflammatory disease, PID, a ruptured ovarian cyst, torsion of the ovary, fallopian tube, ectopic pregnancy with rupture. PID accounts for approximately 20% of acute pelvic pain in females, and ovarian cysts for up to 40%, adnexal torsion about 16%, and 10% of patients who report acute pelvic pain may have extra pelvic disease such as appendicitis. Pelvic inflammatory disease is an infection of the uterus, fallopian tubes, and ovaries. Causes are from bacterial infection, often from an STI like gonorrhea or chlamydia, which has spread from the vagina to the reproductive organs. PID is a serious health problem which can lead to poor long-term health outcomes such as chronic pain, infertility, and ectopic pregnancy. These patients need antibiotics and may require hospitalization if the diagnosis is uncertain. There is a pelvic abscess, there's a pregnancy, or severe illness. The symptoms of PID can vary. Some women, when symptoms do occur, they may include abdominal or pelvic pain, abnormal vaginal discharge with an odor, painful urination, irregular menstrual bleeding, pain during intercourse, high fever in most cases greater than 101, and signs of STI infection. Diagnosis of PID typically involves a combination of medical history, physical examination, lab tests, Perform a pelvic exam to check for adnexal and cervical motion tenderness, cervical edema. Additional tests may include vaginal and cervical fluid samples to check for infection. Blood testing, we may find elevated WBCs and elevated SED rate. And an ultrasound can be ordered to visualize the reproductive organs and check for abscesses. Infertility is on the rise in the United States. On average, 30% of fertile couples will achieve pregnancy within 1 month of unprotected intercourse. 80% will achieve pregnancy within 6 months, and 85% within 12 months. At age 25 years, the age at which couples are the most fertile, the average length of time needed to achieve pregnancy is 5.3 months. The average 20 to 30-year-old American couple has intercourse 1 to 3 times a week, a frequency that should be sufficient to achieve pregnancy if all other factors are satisfactory. Primary infertility occurs in about 1 of 12 couples, or 8.3%. So for failure to achieve pregnancy despite regular unprotected sexual intercourse for at least 12 months is primary or secondary infertility. Diagnostic testing, serial measurement of BBT in male patient semen analysis. And so oftentimes this, you'll refer to a specialist for all of this testing and monitoring, but we all understand the psychological and emotional toll this problem plays on our patients. According to the North American Menopause Society, or NAMS, menopause is the permanent cessation of menses resulting from loss of ovarian follicular function. It is defined as the final menstrual period and is reached when there have been 12 consecutive months of amenorrhea. Menopause often occurs due to aging and represents permanent decline of sex hormones. In addition to aging, menopause can also be surgically induced and medically induced. So, for example, chemotherapy, pelvic radiation, hysterectomy. And the average age of menopause is 51.5 years, and 95% of patients will experience their final menstrual period between the ages of 45 and 55 years. Several tests are appropriate for patients presenting with amenorrhea. Initially, a pregnancy test should be done. That's always your first test. And an elevated HCG could reflect intrauterine pregnancy, a molar pregnancy, ectopic pregnancy, or even certain germ cell tumors. Serum FSH and LH levels may be checked and will be elevated in menopause. FSH levels between 10 to 25 suggest relative ovarian resistance, consistent with menopause transition. The differential diagnoses for patients presenting with menopausal symptoms includes pregnancy, spontaneous abortion, anovulation, endometrial hyperplasia, carcinoma, infection, abnormalities of the uterus such as fibroids or polyps, endometriosis, and adenomyosis, uterine injury. There's a lot of them. So amenorrhea, or when patients experience amenorrhea, there's just a long list of differential diagnosis besides menopause. In addition, the effects of substance use can mimic menopausal symptoms, as can other medications such as thyroid preparations, hyperthyroidism. Absence of menses can also be caused by endocrine abnormalities such as hyperprolactemia, hyperthyroidism, hypothyroidism, as well as excessive stress or exercise. Black cohosh has been used for many years to treat menopausal symptoms. Although the safety and efficacy of this supplement has not been established, there is some evidence that it may reduce hot flashes in some patients, and the incidence of adverse reactions is low. Several pharmacological therapies are available for motor symptoms. Patients with moderate vasomotor symptoms may benefit from SSRIs because they can be effective in reducing the frequency of hot flashes. Menopausal hormone therapy is appropriate for patients with moderate to severe patients who have no contraindications such as breast cancer, as well as a low risk for coronary artery disease, DVT, and stroke. Menopausal hormone therapy has been approved by the U.S. Food and Drug Administration for the prevention of osteoporosis, relief of vasomotor symptoms, and the treatment of vulvovaginal atrophy associated with menopause. There's a nice chart in your textbook regarding the complementary therapies, and I would go ahead and review those. Hormone therapy is contraindicated in patients with hormone-dependent cancers such as breast, endometrial, ovarian cancer, and people with undiagnosed vaginal bleeding. Patients with liver disease, active thrombosis, or history of stroke should not take estrogen, and progestin should be used with caution. Pregnancy is an absolute contraindication for hormone therapy. Migraine headache is a relative contraindication for those use of estrogen because vasoactive properties of estrogen in some patients will worsen migraines. Estrogen has been associated with a small increase in gallbladder disease and also adult onset asthma. An increased risk for the development of systemic lupus erythematosus exists when taking estrogen. However, the incidence is very low. Bone density should be assessed in all female patients over the age of 65 years and in younger postmenopausal patients with risk factors such as small body habitus, tobacco smoking, corticosteroid use, hypothyroidism, fracture following minimal trauma, and a family history of fracture. I listened to Margaret Fitzgerald's STI presentation on your Amplify assignment, and it was pretty high level, and it might be something that you might want to re-listen to again after you understand the basics of STIs, because her presentation was considered an update. And I'm going to try to provide a little bit of information on the screenings for STI. The textbook was not real, it didn't go in depth. And also this is definitely covered on your exam. You will see this in clinical, and it will be on your boards. So sexually transmitted infection, STIs, are caused by viruses, bacteria, parasites, and can occur in the throat, eyes, anal, perianal areas, external genitalia, vestibular glands, vagina, cervix, uterus, or adnexa. STIs are spread through sexual intercourse or intimate person-to-person contact. And if we're talking HIV, when you get in, we're not studying that, but HIV and the hepatitis can also be sexually transmitted. Hepatitis C and hepatitis B can be sexually transmitted. An STI typically occurs when the mucous membranes of the areas are exposed to specific pathogens. The World Health Organization reports that STI diagnosis is commonly missed because many patients are asymptomatic or the symptoms are very mild, so they're not recognized as an STI. STI screening, we are all pretty well informed about the risk factors for STIs, including, unprotected sex, improper use of condoms, multiple sex partners, or having sex with someone who has multiple sex partners, the use of sex workers, having sex with somebody who's recently had an STI, sharing needles. In general, younger individuals are at higher risk for STIs. Nearly half of all STI cases in the United States occur in people under the age of 25. Men who have sex with men are at higher risk with higher rates of HIV and STI. And those who are HIV positive are also at higher risk for other STIs. One STI leads to increased risk for another STI. The USPSTF recommendations for screening for chlamydia are women under age 25 should get screened annually for chlamydia and gonorrhea if they're sexually active. These two problems are grouped together, chlamydia and gonorrhea. Women ages 25 and over who have multiple sex partners or who have sex with someone with an STI should also get screened. Routine screenings are not recommended for men who have sex with women when the women are at low risk for STIs. Sexually active men who have sex with men should be screened annually or more frequently if they have more exposures from multiple partners. Chlamydia and gonorrhea infections can be asymptomatic until PID or prostatitis develops. Lymph node swelling, cervicitis, urethritis, abnormal vaginal or penile discharge, abdominal or pelvic pain, dysuria, itching, dyspareunia may also be reported. Female patients may also report abnormal vaginal bleeding. In advanced infections, fever, chills, and back pain can also be present. For diagnostics, women urogenital infection with chlamydia can be diagnosed by vaginal or cervical swabs or first void urine. For men, chlamydia urethral infections can be diagnosed by testing first void urine or a urethral swab. Rectal and oropharyngeal infection among persons engaging in receptive anal or oral intercourse can be diagnosed by testing at the anatomic exposure site. Methods for STI testing include microscopy culture and NAT, the nucleic acid amplification testing, abbreviated NAAT. So testing may be done based at the point of care, and the choice of the testing method will depend on available of equipment, cost, training, and experience of the people, of the personnel. And you can do self-testing. A lot of times patients can actually do these swabs themselves if they're trained, and but any diagnosis should be, clinically correlated with findings on history and physical examination. The information on chlamydia treatment is coming from the CDC website directly. It's a screenshot. Treating persons with chlamydia prevents adverse reproductive health complications and continued transmission of the disease, so it's important to treat. Treating sexual partners can prevent reinfection, and also infection of other people. Treating pregnant women usually prevents transmission of chlamydia to neonates during birth, and treatment should be provided promptly for all persons with chlamydia infection. Treatment delays are associated with complications such as PID in a limited portion of women. The treatment for chlamydia is doxycycline 100 milligram twice a day for 21 days, or azithromycin 1 gram a single dose, or levofloxacin 500 milligram orally twice daily for 7 days. Trichomoniasis infection, and the majority of people with trichomoniasis or trich either have minimal or no genital symptoms, and untreated infections might last from months to years. Men with trichomoniasis sometimes have symptoms of urethritis, epididymitis, or prostatitis, and women with a trich infection sometimes have vaginal discharge, which can be diffuse, have a foul odor, or yellow-green, with or without vulvar irritation. And they might have a strawberry-appearing cervix, which Fitzgerald described really nicely, which is more often observed on colposcopy than on physical examination. Although many persons might be unaware of their infection, it is readily passed between sex partners during penile vaginal sex, or through transmission of infected vaginal fluids among women who have sex with women. I worked in a university student health clinic, and we did lots and lots of PAPs and lots of women's health. And we had a baseball player for the team, for the college, that was infecting, I don't know how many women with trichomoniasis. And when one of our patients went back to him and told him about the infection, he actually said that he knew he had the infection, and it was his signature. That was one of the most shocking things I had heard. No, there are no routine screenings for trichomoniasis, and diagnostic testing should be performed for women seeking care for vaginal discharge or other symptoms. Annual screening might be considered for persons receiving care in high prevalence settings, such as STD clinics and correctional facilities, and for asymptomatic women at high risk for infection, such as multiple sex partners, transactional sex, drug abuse, history of STIs, or incarceration. However, data is lacking regarding whether screening is effective in preventing disease. Wet mount is traditionally preferred for diagnostic testing, and it's inexpensive and can be performed at the point of care. However, it's low sensitivity compared with culture, and to improve detection, clinicians using wet mount should attempt to evaluate slides immediately after the specimen is collected, because sensitivity will decrease quickly, like 20% per hour after collections. NAATs are highly sensitive, detecting more trichomoniasis infections than wet mount microscopy in women. You can see the CDC chart on the current guidelines for treatment of trichomoniasis for men and for women. Women is metronidazole 500 2 times a day for 7 days, while men are metronidazole 2 grams orally in a single dose. And there's alternative regimen for both. You can review those. For herpes simplex, Dr. Fitzgerald did a great job discussing HSV1 and HSV2, the locations, how you can have them come up positive for either one, and it's complicated, and it's really it's a good idea to understand all this before, because your patients will ask you, how could this be? How did this happen? How did I catch this? And it's really good to be able to tell them and explain to them what's going on. The majority of people infected with HSV2 have not had the condition diagnosed. Many have mild or unrecognized infections, but shed the virus intermittently in the anogenital area. Consequently, most genital herpes infections are transmitted by persons unaware that they have the infection or who are asymptomatic when the transmission occurs. Management of genital HCV should address the chronic nature of the infection rather than focusing solely on the treatment of acute episodes of genital lesions. Clinical diagnosis of genital herpes can be difficult because you have to catch them when the lesions are present. If genital lesions are present, clinical diagnosis of genital herpes should be confirmed. There's also that by Nat culture, but I have seen lab tests for blood tests for HSV since this information came out. As Dr. Fitzgerald explained, when you have a patient with this type of problem, you're probably going to have to look this up. Valcyclovir is the most commonly used treatment because of the dosing regimen. You're going to have a different dose for the first clinical episode. And then for subsequent or recurrent episodes, there's a different treatment regimen. So you have the first episode, the second episode, and then you have suppression doses. Almost all people with symptomatic first episode HSV2 genital herpes subsequently experience recurrent episodes of genital lesions. Intermittent shedding occurs among people with HSV2, even those with long-standing clinically silent infection. Antiviral therapy for recurrent genital herpes can be administered either as suppressive therapy and daily dosing to reduce the frequency and recurrences of episodes and to shorten the duration of the lesions. And certain people, including those with mild or infrequent recurrent outbreaks, benefit from antiviral therapy for the occurrence rather than every day. Many people prefer suppressive therapy, which has the additional advantage of decreasing the risk for transmitting HSV2 genital herpes to susceptible partners. Because remember that what we said, that asymptomatic shedding occurs among people with this infection. In the United States, an estimated 1.5 million new gonorrhea infections occur every year, and it's the second most commonly reported bacterial communicable disease. Urethral infections caused by gonorrhea can produce symptoms among men that cause them to seek curative treatment soon enough to prevent the complications or sequela, but often not soon enough to prevent transmission to others. Among women, gonococcal infections are commonly asymptomatic or might not produce recognizable symptoms until complications such as PID have occurred. PID can result in tubal scarring that can lead to infertility or ectopic pregnancy. Specific microbiological diagnosis of gonorrhea infection should be performed for all persons at risk for or suspected of having gonorrhea. A specific diagnosis can potentially reduce complications, reinfections, and transmission. Testing includes culture, NAAT, and point of care NAAT. They're available for detecting genitourinary infection. Culture requires endocervical swab for women and urethral swab specimen for men. Culture is also available for detecting rectal, oropharyngeal, and conjunctival gonococcal infections. Patient-collected samples can be used in place of provider-collected samples in clinical settings where NAAT for urine, men and women, vaginal swabs, rectal swabs, or oropharyngeal swabs after the patient instructions have been provided. Patient-collected specimens are reasonable alternatives to provider-collected swabs for gonorrhea screening by NAAT. The treatment for gonorrhea has changed since your textbook was released. At this time, ceftriaxone is the recommended treatment, and you can see the screenshot directly from the CDC. And there was a time, your textbook says that the treatment is dual therapy with ceftriaxone and azithromycin, but you don't want to follow that. You want to follow the CDC current guidelines. Things may change though, because the CDC is continuously monitoring for changing the ceftriaxone mics, and that's when you get the culture back. It has a mic rating, MIC, and based on those ratings, they may change. They may add another antimicrobial, but that has to do with the resistance of azithromycin. In cases which chlamydial infection has not been excluded, patients with gonorrhea should also receive anti-chlamydial therapy. The CDC and state departments participate in CDC-supported gonorrhea surveillance activities and can provide the most current information regarding gonococcal susceptibility. How susceptible is the organism in your particular region to the antibiotics? Keep in mind that gonorrhea found on the pharynx may require different dosing. You can look this up at your point of care for guidance when needed. Recent sex partners, i.e., persons having sexual contact with the infected patient less than 60 days preceding onset of symptoms or gonorrhea diagnosis, should be referred for evaluation, testing, and presumptive treatment. If the patient's last potential sexual exposure was greater than 60 days before onset of symptoms or diagnosis, the most recent sexual partner should be treated. To avoid reinfection, sex partners should be instructed to abstain from condomless sexual intercourse for 7 days after they and their partners have completed treatment and after resolution of symptoms, if present. Expedited partner therapy, or EPT, is the clinical practice of treating the sex partners of patients diagnosed with chlamydia or gonorrhea by providing prescriptions or medication to the patient to take to his or her partner without the healthcare provider examining the partner first. And Dr. Fitzgerald explained this very well also. The CDC has concluded that EPT is a useful option to facilitate partner management, particularly for treatment of male partners of women with chlamydial infection or gonorrhea. Although ongoing evaluation will be needed to define when and how EPT can be best utilized, the evidence indicates that EPT should be available to clinicians as an option for partner treatment. EPT represents an additional strategy for partner management that does not replace other strategy such as examination and provider-assisted referral when available. And also, as a nurse practitioner, you have to think about if you have a delegating physician to understand your clinical rules on this and recommendations, because you don't want to end up prescribing something to somebody and having them have, some sort of a complication or an allergy or something that you don't know about, and you end up holding the bag on this, and you're responsible. Syphilis is a systemic disease, and it's divided into stages on the basis of clinical presentation and findings. Primary syphilis clinically presents as a single painless ulcer or chancre at the site of infection, but can also present with multiple atypical or painful lesions. There's a chart in your textbook, and I recommend that you review that, because these sort of knowledge questions regarding staging and things like that are always seen on various tests and courses and on the boards. Secondary syphilis manifestations can include maculopapular rash on the palms and soles of the feet, flu-like symptoms, mucocutaneous lesions, and lymphadenopathy. Tertiary syphilis can present with cardiac involvement, neurological, ophthalmic, auditory, and gummatous lesions. And I knew somebody that had neurosyphilis, and I thought she was on drugs. She was just a little bit confused and flat and just not hitting on all cylinders. Cardiovascularly, it can cause angina, MI, aortic regurgitation, and there's ophthalmic syphilis and hearing loss when it affects the hearing. And so it's important to understand the risk factors and test and diagnose this and try to improve the long-term outcomes for your patients. For syphilis treatment, penicillin G administered parenterally is the preferred drug for treating patients in all stages of syphilis. The preparation used and the length of treatment depend on the stage and clinical manifestation of the disease. Treatment for latent syphilis, greater than 1 year duration, and tertiary syphilis requires a longer duration of therapy because organisms theoretically might be dividing more slowly, but the validity of this rationale has not been assessed. Longer treatment duration is required for persons with latent syphilis of unknown duration to ensure that those who did not acquire syphilis within the preceding year are adequately treated. Parenteral penicillin G is the only therapy with documented efficacy for syphilis during pregnancy. Pregnant women with syphilis at any stage who report a penicillin allergy should be desensitized and treated with penicillin. For vulvovaginitis, you can see the chart from your textbook. Go ahead and review this. Vulvovaginitis is defined as the simultaneous inflammation of the vulva and vagina. The patient typically complains of vaginal itching, burning, and discharge, which comprise the triad of vulvovaginitis symptoms and account for some of the most common reasons female patients seek health care from primary care providers. Although frequently the result of infection, vulvovaginitis may also have non-infectious causes, including allergic reactions, foreign body irritation, atrophic vaginitis, traumatic vaginitis, vulvar disease, or collagen vascular disease. Here is a chart from your book that explains vulvovaginitis, bacterial etiology management. So you can go ahead and look over this. It has the bacterial, it has Trichomoniasis, has atrophic vaginitis, and vulvar lichen sclerosis. Bacterial vaginosis, the mainstay is metronidazole or Flagyl, and this can be orally twice daily for 7 days, or there's also the vaginal gel, and that's for 5 days, 1 applicator full, and that seems to be like an easier solution because it's not systemically absorbed as much, and there's not the precautions related to alcohol, anti-abuse effect. And there's also a clindamycin cream that you can use at bedtime for 3 to 7 days. For the vulvovaginitis with candidiasis etiology, most nurses are pretty familiar with this. You might go ahead and look at this chart. I'm seeing a lot of people want the tablets. They want the doses, the oral treatment. And so be sure and review uncomplicated, recurrent cases, all of that, especially when looking at diflucan, because, I think if you take the full treatment of a topical vaginal cream, you're more likely to have a cure. And that's sort of a clinical pearl. With the oral medication, you can have, you may need to treat again, and you can look at those prescribing guidelines there. Uterine fibroids are extremely common. Their prevalence increases in females between 30 and 50 years of age and decreases with menopause. By age 50 years, 50% of African American and Asian American females have leiomyomas and also or uterine fibroids, and about 30% of European American females have them. So they're very common. The cause of fibroids is unknown, but there's a hormonal link. Females before menarche don't have them, and they shrink after menopause, implicating estrogen as a growth factor. If a pregnant female has a fibroid, it dramatically increases in size during pregnancy, but decreases after delivery. Risk factors for the development of uterine fibroids includes nulliparity, age between 30 and 50, obesity, sedentary lifestyle, and interestingly, smoking seems to decrease the risk for developing fibroids, probably because there isn't enough blood supply. Okay, most leiomas are asymptomatic, and when symptoms are present, abnormal uterine bleeding is the most common presentation. The patient may also complain of pain, particularly during intercourse. If the fibroid is large enough, it can cause pressure on the bladder and sometimes the rectum, resulting in urinary frequency, urgency, urinary pain. Common complaint of abdominal or genital heaviness is also common with large fibroids. So a pelvic examination will reveal a uterine masses, and these fibroids are usually firm and tender. And if there are multiple fibroids, the uterus will feel irregular, nodular in shape, and may be enlarged. Because most patients with uterine fibroids have abnormal uterine bleeding, a CBC can be ordered to evaluate for anemia. Occasionally, a pregnancy test should be done to rule out intrauterine or ectopic pregnancy. And an endometrial biopsy may be done and will be normal, that helps rule out other diagnoses. Pelvic ultrasound or MRI will confirm a diagnosis, and but usually a transvaginal ultrasound is the most commonly used method to diagnose these. That's all I have for the topics for week 4, and I hope you find this helpful. Be sure and reach out if you have questions or concerns, and review. Be sure and listen to the tips at the very beginning about looking at your diseases by, a table and filling it out and writing it down. And you might find this helps with the test scoring. So just let me know if you have any issues. Thank you.